Good morning, everyone. Ovarian cancer fertility-sparing method. Ovarian cancer is the 18th most common cancer worldwide. It's the 8th most common cancer in the woman. A woman's risk of getting ovarian cancer during her lifetime is about 1 in 87. Ovarian cancer rates are highest in women aged 55 to 64 years. The following cancer statistics come primarily from the most recent finding surveillance epidemiology result program of the National Cancer Institute. So, ovarian cancer rate of the highest woman aged 55 to 64 years. Median age at which women are diagnosed with ovarian cancer is 63. The median age of death from ovarian cancer are 70. Ovarian cancer rate, the following tables show total global ovarian cancer incidence and rate in 2022 of women. The highest rate in China, India, and the lowest rate in United Kingdom. Symptoms, the most symptoms commonly of ovarian cancer include bloating, abdominal pain, abdominal distension, pelvic pain, back pain, irregular menstruation, and postmenopausal bleeding, plus pain or bleeding during or after sexual intercourse, loss of appetite, fatigue, diarrhea, and constipation. Urinary symptoms frequency and urgency. Other symptoms include hirsutism, virilization. Risk factor, early menarche, late menopause, obesity, smoking, hormone replacement therapy, diabetes mellitus, polycystic ovarian syndrome, endometriosis, and genetic factor that mean BRCA1 and BRCA2 mutation, which account more than 5% of ovarian cancer. Diagnosis by pelvic examination, by manual examination to palpate any pelvic mass. Imaging tests like ultrasound, CT scan, or MRI. Blood tests may include organ function tests that can help determine the overall health, tumor marker, and genetic testing for BRCA1 and BRCA2 mutation. Type of ovarian cancer. Epithelial ovarian cancer, we have three types of ovarian cancer: epithelial ovarian cancer, germ cell, and sex-cord tumor. I will start by epithelial ovarian cancer. Epithelial cancer can include serous carcinoma, small cell carcinoma, clear cell carcinoma, endometrioid, mucinous adenocarcinoma, plus malignant mixed Mullerian tumor, adenocarcinoma. Serous carcinoma cancer is the most common type of epithelial ovarian cancer. It accounts for about 2/3 of the cases of epithelial ovarian cancer. Low-grade serous carcinoma is less aggressive than high-grade serous carcinoma. High-grade serous carcinoma account for 75% of epithelial ovarian cancer. About 15 to 20% of high-grade serous carcinoma have germline BRCA1 and BRCA2 mutation. Small cell ovarian carcinoma is rare and aggressive with two main subtypes, hypercalcemic and pulmonary. Rare malignant tumor, a malignancy most commonly affects young women under age of 40 years. The mean age of diagnosis is 24 years old. Approximately 2/3 of patients with presence with which act similarly to parathyroid hormone and bind to parathyroid receptor in bone, kidneys, causing hypercalcemia. Most commonly, common initial presentation is rapidly growing unilateral pelvic mass with mean size 15 centimeters. The other type of small cell ovarian carcinoma are pulmonary subtype, which present differently from hypercalcemic subtype. Typically, pulmonary small cell ovarian cancer usually affect both ovaries of the older woman and looks like old cell carcinoma of the lung. This average age of disease onset is 59 years old. Approximately 45% of cases are bilateral, for the pulmonary subtype. Additionally, several hormones can be elevated in pulmonary subtype, including serotonin, somatostatin, insulin, and calcitonin. Clear cell carcinoma, a rare subtype of epithelial ovarian cancer. Those diagnosed with ovarian clear cell carcinoma are typically younger at the age of diagnosis and diagnosed at early stage than other subtypes of epithelial ovarian cancer. Endometriosis has been linked to being the main risk factor for developing clear cell carcinoma of the ovary and has been found to be present in 50% of women diagnosed with clear cell carcinoma. A typical presentation as large with mean size between 13 to 15 centimeter. 90% of cases are unilateral. Endometrioid type, endometrioid adenocarcinoma make up approximately 13 to 15 of ovarian cancer. Because they are typically low grade, endometrial adenocarcinoma have good prognosis. The median age of diagnosis around 53 years of age. This tumor frequently co-occur with endometriosis or endometrial cancer. CA-125 are typically elevated. The other type, malignant mixed Mullerian tumor carcinosarcoma, make up less than 1% of ovarian cancer. They have epithelial and mesenchymal cells visible and tend to have a poor prognosis. Mucinous adenocarcinoma make up 5 to 10% of epithelial cancer. Advanced mucinous adenocarcinoma have a poor prognosis, generally worse than serous tumor. Pseudomyxoma brittonii refers to collection of encapsulated mucinous or gelatinous material in abdominopelvic cavity, which is very rare cause of primary mucinous ovarian tumor. More commonly, it's associated with ovarian metastasis of intestinal cancer. The other type, sex-cord stromal tumor, account for 7% of ovarian cancer. Sex-cord stromal tumor are the most common ovarian cancer diagnosed in women under 30. Sex-cord tumor include granulosa cell tumor, sarcoma, sertoli cell tumor, or adenoblastoma. They are not typically aggressive and they are usually unilateral. Sex-cord stromal tumor, a main hormone producing ovarian tumor. Several different cells from mesenchyme can give rise to sex-cord of stromal tumor. These include fibroblasts and endocrine cells. I will start by granulosa cell tumor. Granulosa cell tumor are the most common sex-cord stromal tumor and divided into two subtypes. We have adult and juvenile. Adult granulosa cell tumor which develop in women over age of 50. Juvenile granulosa cell tumor before puberty or before age of 30. This tumor produce high level of estrogen, which cause of the characteristic symptoms: menorrhagia, endometrial hyperplasia, tender enlarged breast, postmenopausal bleeding, and secondary amenorrhea. Sertoli cell tumor are the most common in women before age of 30. It's in particular common before puberty. Sertoli cell tumor cause virilization, excessive hair growth, due to production of testosterone and androstenedione. Third type, germ cell tumor. Germ cell tumor of the ovary develop from ovarian germ cell. Germ cell tumor account for 5% of ovarian cancer. Germ cell tumors tend to occur in young women, 20 or 30. Germ cell tumor include dysgerminoma, teratoma, leukocyte tumor, endodermal sinus tumor, and choriocarcinoma. Most germ cell cancer have better prognosis than other subtypes and are more sensitive to chemotherapy. The cancer marker used in with tumor type, choriocarcinoma, and monitored with beta HCG and endodermal sinus tumor with alpha-fetoprotein. This melanoma accounts for 35% of ovarian cancer in young women. This tumor may have in the KIT gene mutation known for a role of gastrointestinal stromal tumor. People who are an XY karyotype gonadal dysgenesis or an X0 karyotyping Turner syndrome who develop a unilateral dysgerminoma are at high risk for gonadoblastoma in the other ovary. And in the case, both ovaries are usually removed when unilateral dysgerminoma is discovered to avoid the risk of another malignant tumor. Gonadoblastoma is people with Sawyer or Turner syndrome become malignant in approximately 40% of cases. However, in general, dysgerminoma are bilateral in 10 to 20%. Dysgerminoma contains synthetic trophoblast in approximately 5% of cases and can therefore cause elevated HCG. Cholangiocarcinoma can occur as primary ovarian tumor developing from germ cell. So it's usually gestational disease that metastasizes to the ovary. But primary ovarian cholangiocarcinoma have a poor prognosis and can occur without a pregnancy. They produce high level of HCG and can cause early puberty in children or irregular heavy menstruation after menarche. Immature teratoma or solid teratoma are the most common type of ovarian germ cell, making up to 40 to 50% of cases. Teratoma are characterized by presence of the disorganized tissue arising from all three embryonic, germ cell layer, ectoderm, and endoderm. Immature teratoma also have undifferentiated stem cells that make them more malignant than mature teratoma dermoid cysts. The different tissues are visible on gross pathology and often include bone, cartilage, hair, mucus, or sebum. But these tissues are not visible from outside, which appear to be a solid mass with loops and cysts. Immature teratoma usually only affect one ovary. 10% co-occur with dermoid cysts. There is no specific marker for immature teratoma, but CEA, CA125, CA99, or alpha-fetoprotein may be elevated and indicate immature teratoma. Mature teratoma or dermoid cyst. Mature teratoma tumor consists of disorganized tissue with nodules of malignant tissue, which can be various types. Other type from germ cell embryonal carcinosarcoma, rare tumor type usually found in mixed tumor, develop directly from germ cell, but are not terminally differentiated. In rare cases, they may develop in dysgenetic gonads. They can develop further into variety of other neoplasms, including cholangiocarcinoma, yolk sac tumor, and teratoma. They occur in younger people with an average age diagnosis are 14 years and secreted both alpha-fetoprotein and HCG in 75% of cases. Yolk sac tumor or endodermal sinus tumor. Commonly called endodermal sinus tumor make up approximately 10 to 20% of ovarian germ cells and have the worst prognosis of the ovarian germ cell tumor. They occur both before puberty in 1/3 of cases or after menarche in remaining 2/3 of cases. Yolk sac tumor mainly secreting alpha-fetoprotein. Another types of cancer, mixed tumor, secondary ovarian cancer, and borderline tumor. So mixed tumor contain element of more than one of the above classes of tumor histology. To be classed as a mixed tumor, the minor type must make up to the more than 10% of tumor. True mixed carcinoma can have any combination of cell types. Mixed ovarian cancer are typically serous endometrioid or clear cell and endometrioid. Mixed germ cell tumor with combination of dysgerminoma, yolk sac tumor, and immature teratoma also can happen. Secondary ovarian cancer can also be a secondary cancer. The result metastasis from primary cancer elsewhere in the body. About 5 to 30% of ovarian cancer are due to metastasis. Common primary cancer are breast cancer, colon cancer, appendix, and stomach. Primary gastric cancer that metastasize to the ovary are called Krakenberg tumor. Endometrial cancer and lymphoma also can be metastasized to the ovary. Borderline tumor, the ovary borderline tumor at some called low malignant potential. Ovarian tumor have some benign and some malignant feature. Low borderline tumor make approximately 10% of ovarian tumor. They develop earlier than epithelial ovarian cancer, around age 40 and 49 years old. The typical do not have extensive invasion. 10% of tumor have area of micro invasion, less than 3 millimeters. Clinical staging of ovarian cancer, stage 1, tumor limited to the ovary with a capsule intact, the other ovary not affected, and no malignant cell in ascitic or peritoneal washing. 1P, tumor involved both ovary, otherwise similar to the stage 1, so no malignant cell in the ascitic fluid. Stage 1C, both ovary affected with positive ascitic peritoneal washing for malignancy. Stage 2, stage 3, and 4 that mean metastasis. Management. Treatment usually involves surgery and chemotherapy and radiotherapy. Regardless the subtype of ovarian cancer, surgical treatment may be sufficient for well-differentiated malignant tumor and confined to the ovary. Addition of chemotherapy may be required for more aggressive tumor confined to the ovary. For women with advanced disease, combination surgical reduction with combination chemotherapy regime is a standard. Second lock surgery and maintenance chemotherapy have not been shown to provide benefit. Surgery. Surgery has a standard care for decades. The surgery depends upon extent of the nerve invasion of the other tissue by the cancer. When it is diagnosed, the extent of ovarian cancer is described by assigning it a stage, rhizome type, and grade of the cancer. Surgery usually a total hysterectomy, bilateral saphendoophorectomy, omenectomy, and lymph node dissection. In general, germ cell tumor can be treated with unilateral surgery unless the cancer is widespread or fertility is not a factor. In women with surgical stage advanced epithelial ovarian cancer stage 3 and stage 4, surgery should be made to reach complete cytoreduction or debulking surgery. Fertility-sparing surgery. Also, the most patients with epithelial ovarian cancer undergo radical surgery. Patient with early stage disease, borderline ovarian tumor, or non-epithelial tumor could be offered fertility-sparing surgery, depending on histological subtype and prognostic factor. For patients with borderline ovarian tumor, fertility-sparing surgery should be offered to young women with desire to conceive, even if peritoneal implants are discovered at the time of initial surgery. Women with mucinous borderline ovarian tumor should undergo initial unilateral saphendoophorectomy, whereas cystectomy is an acceptable option for women with serous borderline ovarian tumor. For patients with epithelial ovarian cancer, fertility-sparing surgery should only be considered after staging of women with the stage 1A, grade 1, and probably 2 or low grade in current classification. Serous mucinous or endometrioid tumor. Fertility-sparing surgery could also be offered in patients with the stage 1C, grade 1, or low grade disease. For women with serous mucinous or endometrioid high-grade stage 1A or low-grade stage 1C1 or 1C2 epithelial ovarian cancer, bilateral salpingo-oophorectomy and uterine conservation could be offered to allow pregnancy by egg donation. Finally, fertility-sparing surgery has a large role to play in patients with non-epithelial ovarian cancer, and particular women with malignant ovarian germ cell tumor. Chemotherapy is used after surgery to treat any residual disease. It may result to chemotherapy first, following by surgery. This is called neoadjuvant chemotherapy, and is common when tumor cannot be completely removed or optimal debulking via surgery. Though it has not been shown to increase survival, it can reduce the risk of complication after surgery. If unilateral salpingo-oophorectomy or other surgery is performed, additional chemotherapy called adjuvant chemotherapy can be given. Adjuvant chemotherapy is used for stage 1 cancer, typically if the tumor of high histological grade, grade 3, or high substage, stage 1C, provided the cancer has been optimal staged during surgery. Chemotherapy is curative in approximately 20% of advanced ovarian cancer. It's more often curative with malignant germ cell tumor than epithelial tumor. So germ cell tumor is the more responsive to the chemotherapy. Adjuvant chemotherapy has been found to improve survival and reduce the risk of ovarian cancer recurrence compared to the non-adjuvant therapy in women with early epithelial ovarian cancer. Chemotherapy in ovary cancer typically consists of platines. Platines-based drugs have been used since 1980. Common therapies can include paclitaxel, platin, doxorubicin, and epirubicin. Carboplatin is typically given with combination with paclitaxel. These drug regimes have not been found to be more effective. People with relapsed ovarian cancer evidence suggests topotecan have similar effect on overall survival as paclitaxel and topotecan plus thalidomide. Typical cycle treatment involves one treatment every 3 weeks, repeated for 6 cycles. This is for epithelial tumor. Different regime and germ cell malignancy. Germ cell tumor have treated differently than other ovarian cancer. A regime of PEP regime, called PEP regime, that's combination from pleomycin, etoposide, and cisplatin. It's used for 5 years of 5 days of chemotherapy administered every 3 weeks for 3 to 4 cycles. This germinoma and 6-cord tumor are not typically very responsive. Radiation, radiotherapy, this germinoma are the most common, most effective treated with radiation. In stage 1C and 2 cancer, radiation therapy is used after surgery if there is possible of residual disease in pelvis, but the abdomen is cancer-free. Radiation can also be used as a palliative care for advanced cancer. A typical course of radiotherapy of ovarian cancer is 5 days a week for 3 to 4 weeks. Immunotherapy is a topic of current researches in ovarian cancer. The antibody drugs bevacizumab is used to treat advanced cancer along with chemotherapy. Fertility-sparing method. This is not only for ovarian cancer, but it's for any type of cancer in the body. There are several for preservation of fertility in cases of necessary for radical surgery. Embryo cryopreservation since 1983 with the first case. Embryo cryopreservation is proven a method for fertility preservation. In women with ovarian cancer, this is produced can be performed only if there is no therapeutic urgency, as at least 2 weeks. It's usually necessary to carry out the procedure. It is not recommended in stimulation of ovary after being chemotherapy because proven poor operational result. There is 2 protocols. Preferred protocol, the gonadotropin-releasing hormone antagonist protocol has advantage due to shortened duration of stimulation and a long figure using oocyte maturation with gonadotropin-releasing hormone agonist. Double stimulation and random start protocol. Double stimulation involves 2 stimulation protocols within the same menstrual cycle. The first starting in the follicular phase, then second immediately after oocyte pickup in the luteal phase of the same cycle. So 2 oocyte pickup are therefore performed in approximately 2 weeks apart. Thus, theoretically allow recovery or more oocyte in shortened time period. Random start protocol stimulation cycle initiated in the luteal phase. Luteal were slightly longer and require higher gonadotropin dose when compared with stimulation. Started in the follicular phase. Peak serum estradiol and number of oocyte recovery did not different in between these 2 protocols. Oocyte cryopreservation could be varied in options for patients with unilateral ovarian cancer. Controlled ovarian hyperstimulation is not indicated in case of early intervention nor pre-pubescent patient. The oocyte can be acquired immature or mature. Immature oocytes are acquired without need of stimulation and subsequently are matured in vitro, either before freezing or after thawing. In addition, immature oocytes are more resistant to cryo-injury than mature oocytes, since they don't contain metaphase spindle. Criteria called Renz et al. Criteria show that achieve successful live birth rate through cryopreservation oocyte, at least 8 oocytes required for patients aged less than 38 years, and more than 8 oocytes in patients with aged more than 38 years. This is image for oocyte cryopreservation and embryo cryopreservation. Conclusion: the mean 5-year survival rate for ovarian cancer is 47.4%, but the cancer stage at diagnosis has been strong influenced on through and length of survival. Most common with the stage 1 have an excellent prognosis. Stage 1 patients with grade 1 tumor have 5-year survival of over 90%. As do patients in stage 1A and 1B. This percentage significantly decreased for other stages. Stage 2 has 5-year survival rate approximately 70%, stage 3 39%, stage 4 only 17%. Other factors impact women prognosis, including general health, grade of the cancer, and histotype. Cumulatively, both localized, regional, and distant stages, low-grade serous and endometrioid carcinoma have a most favorable outcome. So it is clear that different cancers need different approach. Moreover, it is important to distinguish non-epithelial ovarian neoplasm because guidelines allow gynecology to perform conservative surgery. Conservative surgery can be proposed in initial stage with adequate counseling. Obviously, the choice must be strictly based on accurate staging of the disease. surgically reached and evaluation of prognostic factor breeding and histotype. This is reference. Thank you.